Okay, let's talk about lid malposition, abnormally positioned eyelids, ptosis, droopy eyelids, and lumps and bumps around the eyelids. Lid malposition and ptosis, ptosis you can think of as a kind of lid malposition, but I'll separate it for reasons that you'll see. So we'll do an overview today, talk about some anatomy, go through history and examination for eyelids specifically, and then get into the causes of lid pathology itself that we'd like you guys to know about. What's the overview? There's your curriculum. This should be on LMS. There's common diseases and there's serious diseases. Serious is a sight to your life or to your eyesight or both. And then there's an intersection. Lid stuff, it fits both, because if you think about an acute Horner syndrome, for example, that gives you a ptosis, acute Horners can be due to dissecting carotid artery, right? ICA dissection. So there are some causes of lid malposition which can be a threat to sight, if not life. Another way to think about ophthalmology is patients will generally present with a painful red eye, or with visual disturbance, or with both. And I've put lid malposition and tumours in visual disturbance because if your lid's in the wrong position, it'll often affect your vision. You can present with a red eye as well. So arguably it could also be both, but for the sake of our Venn diagram, that's where it is. Our objectives for me, for you for today, is some basic anatomy, which will help you understand the pathology, a relevant history and examination, and to diagnose and manage the important lid conditions. The example that I've given here in the top image, the patient's left eye, so your right, as you're looking up there, you can see as he's got his eye closed, part of his white sclera is on show. Do you agree? In his left eye. That's not normal. It's not there in his right eye. The majority of you will not have this, if not all of you. And you can imagine when this guy sleeps at night, the part of his eye that's exposed is going to dry out really badly. So he's going to wake up, he's going to present with, 75-year-old man presents with gritty, painful, scratchy left eye on waking every morning that gets better throughout the day. Okay, so there's incomplete lid closure. The ophthalmic term for that is lag ophthalmos. It's one of the lid malpositions, which I'll be telling you about today. This is the kind of photograph we're going to expect you to be able to interpret. I think someone off the street could interpret that photograph, right? Because with his eyes open, he looks normal. With his eyes closed, there's an asymmetry. So asymmetry is one of the key things that you want to look for. Why do eyelids matter? This is still in our overview. Think of them as the gateway to vision. They're the first thing that light encounters as light travels towards the eye. Light being important because it's the basis of all vision. Without light, there's no vision. The roller shutters are the eyelids, right? Without eyelids, you would go blind in a matter of days to weeks because the cornea is exposed. Cornea needs to be covered, constantly lubricated. That's why we blink constantly. And the eyelids and eyelashes are protecting us from foreign bodies all the time, right? So you don't get stuff in your eye, when you don't get sand in your eye when you go to the beach. So they're critical. When you have pathology, you get damage to the ocular surface, which is painful. It's a risk factor for infection, and it's definitely a possible threat to life. If you have a look at the top image there, looks uncomfortable, doesn't it? So his lower eyelid is turned out. That's called an ectropion. The bottom image is him having had a skin graft. If you look carefully, you can see there's a little line there where the color of the skin is different, and it's corrected his lid position. He's going to be a lot more comfortable and safer as a result of that. Also, eyelids they're on your face, so they affect your self-esteem. If you've got a really deformed eyelid, you're not going to be very happy, particularly as a younger person. So people are having lid surgery all the time for this reason. It affects their quality of life and their self-esteem. Finally, 10% of skin cancers are on or around the eyelids, and we'll be talking about those. Today, some of them are a threat to life. Treatment's usually surgery. It's a very surgical subspecialty. So the subspecialty we're talking about here is oculoplastics. It's not my subspecialty, but it's people who operate on the eye socket and on the eyelids. There's a handful of them in town. And something that you should do if you end up being a GP is learning who is your nearest oculoplastics subspecialist And as I say, there's half a dozen of them in Perth. There's not that many. So when you get a possible skin cancer, you know who to refer to. Let's quickly go through some anatomy. This doesn't need to be in crazy detail, but in a nutshell, the eyelid is what we call a bilamellar structure, as in there's two main layers. There's actually three, but let's just talk about two. One is a hard fibrous layer called the tarsal plate. Okay, so this is hard connective tissue. There's an upper tarsal plate and a lower tarsal plate. This gives the lid its shape and maintains that shape. Otherwise, you've had what's called a floppy lid, right? Which is actually a diagnosis, floppy eyelid syndrome. On top of the hard tarsal plate, you've got muscle, fat, blood vessels, nerves, and skin. Okay, so you've got a soft tissue layer on top of the tarsal plate. The anterior lamella, the skin muscle part, contains lots of glands, the main one being the lacrimal gland and the meibomian glands. Lacrimal gland produces clear fluid, tears. Meibomian glands create more of a sebaceous secretion, an oily film. So between the two of them, that's what keeps the corneal surface lubricated. And the important nerves are seventh nerve, closes the eyelids, third nerve opens them, and then you've got sympathetic fibers which also contribute to opening, right? That's why in Horner's you get a ptosis, because it's sympathetic denervation, right? And in a Bell's palsy or a seventh nerve palsy, person can't close their eye. They get incomplete closure. There's also the lacrimal drainage system. There's a picture of it there. So you can think of this as two gutters and a downpipe back into the back of the nose. So if I was to put stuff in your eye, eventually it would drain into the back of your throat, okay? So this is called the nasolacrimal system. It's one of the other functions of the eyelids. So the functions to talk about that, protection that we've already talked about, then lubrication, producing the tear film, distributing the tear film through blinking. We blink about once every 6 seconds on average, and that's to constantly replenish the tear film and then to drain those tears, okay? So it's production, distribution, and drainage, and then cosmesis and expression. I'm using my eyelids unconsciously while I'm talking to you right now, right? For expression, so that's important. Questions so far? Make sense? Okay. History and exam. Well, I guess the thing we want you to be aware of, two main things. One is the lid position. If someone has a lid malposition, they'll generally come and tell you, my eyelid looks abnormal. The exception to that is the guy with lag ophthalmos, the image that I put up earlier, where he'll come in presenting with painful eye or red eye. You can have both, of course. You can have lid malposition and pain. As far as lumps go, gradual enlargement is what you're looking for. If there's a lump that's been there for a very long time, hasn't changed at all, decades, it's unlikely to be neoplastic. Not impossible, but unlikely. Here's an example of a fairly common benign growth. This is seborrheic keratosis. But you don't know that really unless you see these every day or you've known the patient for 20 years. When in doubt, refer. That's one of the take-homes from today. Other symptoms, if they're coming with acute lid malposition, then you have to think of third nerve palsy, seventh nerve, or Horner's, one of those neurological causes. Do they have other neurological symptoms? Do they have a history of cutaneous cancer, BCC, SCC, in particular melanoma? Have they had a lot of sun exposure? Are they an outdoor worker? Are they a smoker? So all the risk factors for skin cancers. And then beware a chronic non-resolving chalazion or sty in quotation marks, right? Because an inflamed looking lesion that's been there for months and months and months or even a couple of years rarely will be a sebaceous carcinoma, which is a highly neoplastic lid lesion. A normal chalazion or sty should be resolving in weeks, if not days. So it's chronic, that's a potential red flag. Examination-wise, general inspection, fair-skinned, dark-skinned, higher risk of cancers in fair-skinned people, you guys know that. Although that's not to say an olive-skinned person like me can't get a skin cancer. Of course I can. As far as the lids themselves go, lid height is important. when people come in talking about a droopy eyelid, you can get really technical about lid height, but a simple examination technique is to take your ophthalmoscope at about arm's length from the patient, shine it at the patient's eyes, and you're looking for the reflection on the cornea, right? You'll get the light from the ophthalmoscope reflecting on the cornea, and it should be more or less in the middle of the cornea. Have a look at the distance from the top eyelid to that reflection in one eye and compare it to the other eye. It's about 2 to 3 millimeters. If there's a big discrepancy, you'll see that. There's not much of a gap between the corneal reflex and the top lid and also the bottom lid, because you can get an inferior ptosis as well, or inferior lid malposition of other sorts. So that's the key examination skill, is where is the lid position relative to the corneal light reflex, and is it symmetric or asymmetric? Then you can look at the lid contour. Is it turned in? Is it turned out? Is there a lump on the lid contour? The lid contour should be a smooth ellipse, right? Downward ellipse for the bottom lid, upward ellipse for the top lid. Then look at the color. Is there a discoloration? Is there a red bit? Is there a dark bit that looks a bit like a melanoma? You get what I'm saying? And also don't forget to evert the lids. So eyelid eversion is part of a full ophthalmic examination, including when you're examining the eyelids, because you can get little tumours hiding up underneath the eyelid. As far as lumps go, these are the critical things to look for to try and differentiate between a benign lump and a neoplastic lump, right? So ulceration, if there's a central ulcer, benign lesions don't do that. If there's loss of eyelashes, we call that matarosis, but you can just call it lash loss. So adjacent or within the lump, have you lost eyelashes? Are there lots of blood vessels, telangiectasia, in and around the lump? And do the borders look somewhat regular or very, very irregular? Irregular being worse. They're the sort of things to look for. And then don't forget pupils and eye movements. That's part of your neurological examination, particularly in the setting of a ptosis. That's where that's really relevant. So in a third nerve palsy and a Horner's, you'll get abnormal pupils, and in a third nerve, you'll also get abnormal eye movements, right? And then corneal fluorescein staining. If they're not able to close their eyes properly for whatever reason, then the corneal surface, you'll get fluorescein staining. And you'll learn a bit more about this in your workshop. Okay, so that should be part of the examination. And then if you're worried about a possible cancer, the submandibular and preauricular lymph nodes, that's where the eyelids drain to. So you want to palpate those. Finally, anytime anyone asks you, what would you like to examine, mention this mnemonic, right? Afro-C. This should get drummed into you this term. So in an OSCE, often we'll say, what would you like to do? And a student will say, oh, I think I want to measure the vision. And I go, okay, here it is. What else? And then there's a blank. Always have this mnemonic up your sleeve. This is the full ophthalmic examination. So you're always going to do this, and then you may do some stuff in addition, such as an eyelid exam, if that's what's relevant. So hardwire this one into you. And then this is mentioned in all of the other lectures. It'll be mentioned in the workshop. It'll be reinforced several times. Now, what about the causes of lid pathology themselves? Let's move on to those. This is what we're going to talk about. So let's get into it. Okay. 75-year-old man presents with uncomfortable right eye. What's the obvious abnormality? Typical OSCE station, typical real life scenario. The obvious abnormality appears to be his right lower lid. I'm going to use simple language. His right lower lid looks red. Just start with that. Examiner's going to go, great, thank God. Oh, going to make my life a bit easier. Then you look at it a bit more closely. The right lower lid looks lower slightly than the left lower lid if I look at the eyelashes. And once you've seen a couple of these pictures, you'll realize that his right lower lid is actually turned out. It's turned outwards. So he's got a right lower lid ectropion. Yay, tick. What examination would you like to do? Afro-C. And I'd like to take a closer look at his, you get the picture. Similar age person, presents with foreign body sensation in their left eye. What's the obvious abnormality? Wow, look at those eyelashes. Instead of pointing down in the lower lid, the eyelashes are pointing up. And they appear to be making contact with the bottom part of the cornea, the bottom part of the eye. Of course, that feels like a foreign body. It is. Lashes shouldn't be poking into the eye, right? So this is an entropion, not an ectropion, but an entropion. Entropion is lid turned inwards. Other things that can cause lashes pointing towards the eye, but the common one is entropion. And what's the obvious abnormality here? Younger person, so it's not going to be an age-related change. It's more likely to be something acute, trauma, iatrogenic from surgery, or neurological vascular, right? They're the sort of etiologies you think about in a younger person. What's the obvious abnormality? She can't close her right eye, right? The top right eyelid isn't coming down. So she's got incomplete closure of the right upper lid. What causes that? Seventh nerve palsy, because we talked about anatomy, right? Seventh nerve closes the lid. What's the most common cause of a seventh nerve palsy? Idiopathic Bell's palsy. Although if there's associated neurology, often you have to work these patients up more than that, but that's the most common scenario, post-viral Bell's. So what are the most common causes? The most common is involutional, meaning degenerative, age-related, okay? So the ectropion and the entropion that you saw, they're the most common things you'll see in GP, and they're most commonly involutional. Cicatricial, so involutional really means that some tissues are going floppy and lax, and as a result, the lid is flopping inwards or outwards, whereas it should be firm, usually, right? Cicatricial means that something's pulling on the eyelid, and often this will be in the setting of there's a skin cancer creating traction, there's a skin cancer that's been operated on, and the scar is creating traction. They've got a type of skin condition which causes traction, like pemphigoid, ocular pemphigoid. They're the sort of common scenarios: trauma with a scar formation or radiation around the eye socket. They're the cicatricial causes, and normally you'll see that in a photograph. There'll be a big obvious scar there, right? So okay, I've got a cicatricial entropion, right? Paralytic we've talked about, so seventh nerve palsy. And then physiological, you might just get a bit of asymmetry. There's actually not a great deal going on. It's not that symptomatic. That can be observed. You don't have to intervene. How do they present? Irritation, we've talked about. Redness, epiphora means watering. So if the ocular surface is irritated, generally it'll produce more tears. So say, oh, I've got a red watery eye, it's really annoying, it's gritty. That's your presentation. If the ocular surface isn't happy, vision is going to be blurry. The surface should be like a clear window. If it's scratched up, which is basically what happens when the lids don't work properly, it's like a scratched windscreen. So they're going to get blurry vision. And then, as I say, you look for scars that are clues. Lids might be turned in or out. You may have a seventh nerve palsy with incomplete closure. So that's your sort of typical presentation. What's your differential here? Always think about malignancy. Could it be a tumor that's yanking this lid into an abnormal position? And then a proptosed eye. So most common cause of proptosis, prominent eyeball. Proptosis is the eye being pushed anteriorly, right? The most common cause there is thyroid, and thyroid can be asymmetric. If one eye is pushed forward, it might look like, in fact, not look like, the lids might not be able to close properly, right? And it can make the other eye look like it's got a ptosis. Right? It's a bit paradoxical. But if one eye is actually pushed forward, it can make the normal eye, the lids get pushed backwards, right? If the eye gets pushed forwards, makes the normal eye look like the lids are too far down. So there's not a ptosis. It's actually the proptosed eye, which is abnormal. That's called lid retraction. So that can be, thyroid is not uncommon. Have that as a differential in the back of your mind. A tumor can do the same thing. Tumor is less common. What's the management here? It's surgical. If it's bad enough, it's surgical. So you refer to us, and an oculoplastic surgeon will correct the underlying deficit. Here's an example. The top image, you've got involutional ectropion in both eyes. It's really quite pronounced. The pink that you're seeing is actually the inside of the eyelid, right? That's the conjunctiva, the mucous membrane that covers the inside of the eyelid. And it's on display to the world. It doesn't look very nice, and it's probably uncomfortable. And you can see it's really nicely corrected there. If they've got a seventh nerve palsy, then they'll have a metal weight, actually, once the lesion's stable, so you know where the lid is going to sit. They'll have a metal weight, little gold weight, inserted into, so mechanically it pulls the top lid down. And that can stay there for years and years. And in the meantime, most lid conditions, the eye is going to need extra lubrication because it's at risk of drying out. So you can definitely start your lubricating drops then and there in GP, ED, wherever you're seeing them, whilst they're waiting to be seen by ophthalmology. In a seventh nerve palsy, you can also use skin tape to tape the eyelid shut at night time. Put some cream in the eye and then tape the top lid down to the cheek. That'll give them some overnight protection. If you've got an atypical seventh, as I mentioned earlier, they can need involvement from neurology and possibly neuroimaging. So these guys tend to do really well with surgery. The complication rate is low. Recurrence is not zero, but it's low. So in most cases, it's a very manageable condition, and their quality of life will improve, potentially their vision as well. Okay, so let's move on. What's the obvious abnormality here? We've got an older patient who appears to have a right ptosis. If I look closely at the eye, left eye is looking straight at the camera, right? That corneal light reflex that I talked about, well, it's not even visible in the right eye, where it is visible in the left eye. And also, the position of the eye appears to be turned outwards and down. If you can see the bottom of the cornea and the iris, right? And it's not facing the camera straight on. That bit might come a little bit with experience, knowing that the eye's turned out. But even if you're not confident whether it's turned out or not, you have to be thinking about a third nerve palsy, right? So this is an acute unilateral ptosis. That's a cause. Acute, you have to think third nerve palsy, Horner syndrome. And there's a whole other lecture, one of the online ones, that's about pupil abnormalities, and those two conditions are covered. So watch that if you haven't already. We've got a left-sided ptosis here. And for extra marks, what you might notice is that his left eyebrow is pulled up a lot higher than his right eyebrow. So he's using his brow, which is the muscle up here, which is a separate muscle to the muscles that supply the eyelid. He's using his brow to try and pull his eyelid up. Okay, I do that a bit. I've got a little bit of litosis, and so I use my brow to pull my eyelids up, but it's not this marked. This is clearly really asymmetric, right? So he's got a left-sided ptosis. His eye is not turned down and out. So if this is a chronic presentation, let's say it is, it's been there for 6 months, this is going to be involutional. Remember I used that word earlier? Degenerative meaning, tight muscles becoming floppy, tight connective tissues becoming floppy, and the whole thing flops down like a floppy curtain, right? Just falls to the ground. Here's a baby with a left-sided ptosis. So this is a congenital ptosis. It could be idiopathic, but you have to think of neurological causes here, and they need to be seen urgently. They need to be seen within the next couple of days by a pediatric ophthalmologist. So not necessarily an oculoplastic specialist, but pediatric ophthalmologist. There's also a separate lecture on pediatric ophthalmology, so have a look at that as well. So they're the causes of ptosis. Involutional is by far the most common. Neurogenic, if it's acute, myasthenia gravis can do that. So that's a differential. If it doesn't look like the other two, the third nerve and the Horners. And then if they're born with it, can be congenital idiopathic, can be congenital if it was a forceps or other instrument delivery from damage to the lid muscles. And then if there's an obvious, you want to ask, have you had an accident? Did something hit your face? Is there an obvious tumor on the lid or on the brow? Could they have another myogenic condition such as myotonic dystrophy? Okay, there are your other causes and differentials. The key thing here really is whether it's acute or chronic. That'll be your biggest clue. And then pediatric congenital versus older acquired. And if you've got pain, think of a third nerve or a Horner's. They can be painful. The others don't tend to be. Diplopia, think of a third. Pupil abnormalities, third or Horner's. Patient might say, I look tired, or people tell me I look tired. Field limitation is important with regard to driving. So if they've got a complete ptosis, or if it's a pretty severe one, then they may well not meet the visual requirements for a driver's license. And if there's a suspicion of that, they need to have their visual fields tested formally by one of us. So that's a reason for a referral. And trauma or surgery we've talked about. The differentials here are dermatochalasis. Dermatochalasis is redundant or excess skin on the upper lid, just a bunch of baggy, floppy skin, the top image there, but the lid height is actually fine. So it's like an apron sitting on top of otherwise normal lids. You just need to get the apron out of the way. That's blepharoplasty surgery, which is very common. So this man has had dermatochalasis. It's not a true ptosis, right? You can have both, gets confusing. You can have excess skin and a ptosis. So that just needs evaluation by a surgeon. And then brow ptosis happens not when the lid is paralyzed, but when the brow is paralyzed. So that's a seventh nerve palsy affecting the lower motor neuron only, right? So that will paralyze your brow, the whole thing drops down, but your blinking is actually fine. It's just that the brow can't elevate anymore. I wouldn't give you that in an exam. That's kind of gold star material, but you might well get the dermatochalasis because it's so common, right? What's the management here? Exclude the neurological stuff, and then it's ophthalmology for lots of various types of surgery for different types of ptosis. And here's an example. So a young lady with a left-sided ptosis of unknown cause, let's say, and you can see after surgery, she's much more symmetric. So that's a really good cosmetic outcome for her. They might need systemic treatment if it's a systemic condition. And then in kids, they may also need amblyopia treatment and strabismus treatment. I won't go into those now. There's lots of that in the lecture on pediatric ophthalmology, but the takeaway is don't leave a kid with a ptosis, because if it's there for long enough, they're going to lose vision in that eye. Even if there's nothing else going on, visual deprivation, which means there's a barrier up in front of the eye, in a newborn, infant, toddler, or child under, let's say, 7 to 10 years of age, will quite quickly lead to loss of vision, which is potentially irreversible, because seeing is actually the stimulus for being able to see is the stimulus for improving your eyesight. That's how visual development works. So if you cover these experiments on cats where they cover their eyes from birth, cat ends up blind. It's really cruel. I don't think it'll get ethics now, but that's how visual development works. So don't leave a kid with a ptosis. Again, the prognosis is good. The surgical results are generally very good. Recurrence is higher with ptosis surgery, so they may end up getting 2 or more surgeries. Moving on to the last bit, which is lid lumps. So here we have an ulcerated lid lesion. Do you agree? There's a central ulcer there. It's discolored. The margins of the lesion are raised. There's no lash loss. There's probably some telangiectasia. It's hard to say. The photo's not in very good definition. So you'd be worried about a neoplastic lesion here. What's the most common one? Basal cell carcinoma. 80% of neoplastic lid lumps will be a BCC. Here's an SCC. Looks somewhat similar. Can be difficult to differentiate the two. They don't tend to have the sort of, we call it a pearly edge. The edge of the BCC looks like little pearls. SCCs don't tend to have that as much. In a sense, it doesn't matter. Both of them can be dangerous and need urgent to semi-urgent, meaning within a couple of weeks. Okay, review. Here's a benign lesion. So this is a papilloma. This is one of the more common benign lesions, and it can be caused by papillomavirus. It can be idiopathic. If you look for these, you'll see them all the time. And they've got that typical variegated appearance. Variegated is just describes the appearance. Sometimes a patient just won't like the look, so we can excise them for that reason, and you send them off to pathology just to make sure that you don't get a surprise. And then a pigmented lesion is most commonly a nevus, but you've got to worry about melanoma. So they may need a biopsy. So as I say, most common thing is BCC, followed by SCC. That's the majority of neoplastic tumours. Then there's lots and lots of rarer ones. And the benign ones include the papilloma, which I just showed you, and the seborrheic keratosis, which I showed you right at the start of the talk. You can go back and review that slide. Looks like a piece of coral, seborrheic keratosis, or a little plaque is how it's described, a discrete little plaque. Beware a non-healing ulcer. That's how a lot of these present, that ulcerated centre. The pearly sort of nodular border, as we saw there. They can cause lid distortion. And then all those other features that we talked about at the start that are suspicious. Loss of eyelashes, bleeding, telangiectasia. Benign lesions won't do that. Differential here is a Claisian or a sty, which overall are much more common. But as I mentioned earlier, beware if they're not resolving. They should resolve. Nevi are also not uncommon. And you don't need to, there's an extensive list of other benign and malignant lesions. Just know that it could be something else. Don't biopsy them because if the GP performs a biopsy or someone else performs a biopsy, it can end up making the lesion invisible. And then the surgeon doesn't know where to cut. So the best thing is to leave it alone, take photographs, and in case it changes in size, and then get them in to see someone within a week or two. What the ophthalmologist will do is potentially do a biopsy, or they may just go straight to a margin-controlled excision, and there are different surgical techniques for that. There's what's called frozen section, there's Mohs micrographic surgery. The principles there are that during the operation with Mohs micrographic, the surgeon slices off part of the tumour. That gets looked at under a microscope in real time to see if he's got all of it or not. So there's the example there where it says level 2. If it's clear that there's still tumour there, he'll shave off a bit more, gets looked at again. There's a little bit left. He'll then target those areas. So as little normal tissue as possible is being removed with this surgery. It's an excellent technique to leave normal tissue behind whilst removing all of the tumour. So all these techniques are available, but the point is that you're getting rid of the whole tumour margin so it doesn't recur. And in addition to that, some patients might need cryotherapy, topical or systemic chemo, or local irradiation. Those things are less common, but they're definitely part of the management options. And then if it's an orbital tumour, if it's a severe aggressive tumour with orbital or systemic involvement, then obviously oncology or radonc might be required. Prognosis for BCC is very good, particularly if it's caught early. And, the risk factors for worse outcomes are hopefully intuitive. If it's bigger, that's worse. If it penetrates deeper, that's worse. If it goes into the eye socket, if it's been there for longer, if it's penetrated the nerves, all those things are worse, and they generally come with chronicity, or if it's been treated inadequately. So the key here is low index for suspicion and early referral. This is from the College of GPs, and I don't think you need to memorize all of this. Memorize what's in those preceding several slides, but it just gives you a good snapshot of how to think about lid lesions. You've got lesions that are completely benign, cysts and chalazions and so on. You've got tumours that are benign, papillomas that I showed you, and then you've got tumours that are malignant. So I think of it in sort of that framework. It's a good organised way to think about things. Okay, so to wrap up, most lumps are benign, thankfully. Most lid position is age-related, involutional, or degenerative. But watch out for the red flags. don't miss a skin cancer, or, look for a skin cancer as a cause of lid malposition. An acute ptosis is a red flag, or acute incomplete lid closure plus other neurology. They need a scan. There's a seventh nerve palsy. He can't close his top lid and his bottom lid is sagging. So his right corneal surface is going to be shot, which is why his eye is red. So that looks uncomfortable. It is uncomfortable. And then look for enlarging lesions with damage to the tissue around them. So, invasive tumours or a neoplastic tumour is what tends to do that. Here's an example of lash loss. I've talked about eyelash loss. Here are the lashes, they stop there, they restart here. And you've also got a little divot in the lid margin, and you've got telangiectasia. So you've got all the hallmarks there of a neoplastic tumour, probably a BCC. Early referral to oculoplastics is the key, and in the meantime, treat the ocular surface with lubricants, use lid taping if they're not getting complete closure. Hopefully we've checked off those things. And I finished 1 minute later than scheduled, so that's not bad.